rapid fire clinical review, trauma, and basic life support. Let's get right into it.
Question 10. Okay, so we've got a middle-aged male who is hemodynamically unstable from polytrauma presenting to the surgical emergency department. What should be our absolute first priority here? Are we going with option A, perform whole-body CT, B, X-ray chest, C, fluid resuscitation and treatment of shock, D, fast scan, or E, X-ray pelvis? And the correct answer is C, fluid resuscitation and treatment of shock. Listen, if you've got an unstable hypotensive trauma patient, you have got to support their physiology immediately with active resuscitation. You literally cannot waste time on prolonged non-interventional diagnostic studies. The absolute rule here, if a patient is too unstable to safely transport, do not send them off to some distant radiology suite. You stabilize them right there with a pelvic binder, secure access, start empirical blood products, and go straight to the OR if you have to. Now, a quick pearl, in modern advanced trauma centers, they actually put the whole body contrast CT scanners right next to the resuscitation bay so you can resuscitate and image at the exact same time. Moving right along, question 11. We have a 44-year-old polytrauma patient following a high-speed motor vehicle collision. They are hemodynamically unstable. Fluid resuscitation is already going. During your primary survey, you strongly suspect a pelvic fracture. So, what is your immediate step? A, immediate laparotomy and ligation of bleeding vessels. B, angioembolization. C, extraperitoneal packing of the pelvis. D, application of a pelvic binder. Or E, application of an external fixator to the broken pelvis.
It's D, application of a pelvic binder. This is absolutely crucial. Blunt pelvic disruptions massively increase the internal volume of that retroperitoneal space, which basically invites massive, low-pressure venous bleeding. It's like a balloon filling up with blood. By immediately applying a commercial pelvic binder, you compress the pelvic ring, shrink that internal volume, and create a local tamponade effect while stabilizing those raw bone fragments. For your exams, remember to center the binder directly over the greater trochanters of the femurs, not the iliac crests. And here are your major procedural don'ts. Never, ever manually spring or rock the pelvis on exam. You'll just break up the retroperitoneal clot that's keeping them alive. Don't do formal log rolling. Use a scoop stretcher instead. And finally, do not take the binder off during an emergency laparotomy. It doesn't get in the way of a midline incision.
Question 12. Regarding tourniquets, which of these statements is correct? A, should be tied just above the elbow. B, should be tied just below the elbow. C, upper limit of pressure in the leg is more than 400 millimeters of mercury. D, time should not exceed more than 1 hour. Or E, upper limit of pressure for the arm is more than 200 millimeters of mercury.
The right answer is D, time should not exceed more than 1 hour. To really minimize the risks of profound tissue ischemia, systemic metabolic acidosis when you release it, and localized nerve damage, you ideally want to deflate pneumatic surgical tourniquets after 1 hour for just a few minutes. The absolute hard maximum safe ceiling for continuous inflation is 1.5 hours, no exceptions. Let's look at the setup taxonomy real quick. Apply it as proximally as possible where those thick muscle bellies can protect the nerves. Your cuff width should be about 10 centimeters for the upper extremity and 15 centimeters for the lower extremity. For pressures, aim for 100 millimeters of mercury above systolic for the upper limb and 150 above systolic for the lower. Oh, and definitely avoid these entirely in patients with documented peripheral vascular disease or sickle cell disease.
Question 13. What is the most common complication of a tourniquet? Is it A, allergic reaction, B, skin necrosis, C, vascular injury, D, nerve injury, or E, skin necrosis? Yeah, skin necrosis is there twice, but let's see what the actual answer is.
It's D, nerve injury. And the mechanism here is actually fascinating. When you apply that mechanical compression, the tourniquet basically crushes the nerve trunks right against the underlying bone, which causes localized ischemia of the nerve sheath. The large diameter myelinated fibers are the ones most sensitive to this. In the upper extremity, the radial nerve takes the hit most frequently, while in the lower extremity, it's the sciatic nerve. The typical pathology we see is neuropraxia. That's a temporary conduction block. The axon isn't actually structurally torn, so it generally resolves on its own over a few weeks or months.
All right, question 14. Which method should be used initially to prevent bleeding from a traumatic below-knee amputation? Let's look at the options. A, limb elevation. B, direct pressure application with sterile gauze. C, suture ligation of vessels with silk. D, tourniquet application high up. Or E, none of the above.
The correct answer is B, direct pressure application with sterile gauze.
I know it sounds crazy, but even with severe traumatic amputations, your very first line response is always direct pressure right over the bleeding site using sterile packs or gauze. This handles most of the bleeding, but still preserves whatever distal collateral tissue perfusion is left. Now here's your key exam pearl. If direct pressure fails, then you apply a tourniquet. But it needs to be at least 10 centimeters proximal to the wound margin. Why? To make sure you fully capture those severed arterial stumps that have retracted back up into the leg.
Question 15. In two-person rescuer adult resuscitation, what should the chest compression to ventilation ratio be?
It's C, 30-2. For adult CPR, that compression to ventilation ratio stays locked at 30-2, and it doesn't matter if you have one rescuer or two. This is the physiological gold standard to maximize continuous blood flow to the vital organs during cardiac arrest. You have to keep that blood moving.
Next up, question 16. In two-person rescuer infant resuscitation, what should the chest compression to ventilation ratio be?
The answer is B, 15-2. This is an important distinction. For infants and children, if you're a single rescuer, you stick with 30-2, but the second another rescuer shows up, you switch right to 15-2. This shift fundamentally prioritizes oxygenation and ventilation. Why? Because unlike adults, the most common cause of pediatric cardiac arrest is respiratory arrest. We have to correct that hypoxia. Let's put this all together and compare these age groups directly in this explainer. For adults, it's always 30-2, compressing at least 5 centimeters deep with 2 hands. For kids, it's 30-2 for one rescuer, shifting to 15-2 for 2, going about 5 centimeters deep with either 1 or 2 hands. Now for infants under a year old, it's 30-2 for a single rescuer and 15-2 for 2 rescuers, but the depth is only about 4 centimeters. And pay close attention to hand placement for infants. A single rescuer uses 2 fingers, but when you have 2 rescuers, you highly prioritize that 2 thumbs encircling technique.
Question 17. Say a single rescuer finds an unconscious child on the roadside. The child has a normal pulse, but they are not breathing. What is the appropriate ventilation rate from our options here?
It's A, 1 breath every 5 seconds. Since we've confirmed the patient has an adequate peripheral pulse, so 60 beats per minute or greater, but they are completely apneic, you don't need chest compressions. You're just delivering pure rescue breaths. Deliver each breath over exactly 1 second, make sure you see that chest rise, and recheck the pulse every 2 minutes. Now, pearl to remember, if that pulse drops below 60 and the child is showing signs of poor systemic perfusion, you drop the rescue breathing and start full CPR cycles immediately.
Question 19. Actually, scratch that. Question 18. An unconscious adult is found on the roadside with a normal pulse but no breathing, and you are a single rescuer. What is the appropriate ventilation rate? Just like the last one, the matching correct answer is A, 1 breath every 5 seconds. Pacing it exactly like this gives you exactly 12 breaths per minute. That is the precise standard required to correct respiratory hypoxia in an adult without needing to do compressions. Okay, let's hit question 19. What is the initial management to keep the airway patent in a patient who has suffered head trauma and crucially has a suspected C-spine injury? A, jaw thrust, B, head tilt and chin lift, C, endotracheal intubation, D, cricothyrotomy, or E, none of the above?
The answer is A, jaw thrust. Listen, head trauma is so frequently tied to occult cervical spine injuries. If you use the standard head tilt and chin lift maneuver, you're hyperextending the neck. That can easily displace unstable cervical vertebrae and cause absolutely catastrophic, irreversible spinal cord injury. We do not want that. The jaw thrust maneuver elegantly solves this entire problem. It opens up that upper airway by pulling the angles of the mandible forward, which clears the tongue right out of the hypopharynx, all without moving the cervical spine even a millimeter. So think about it. Could mastering this one simple, basic anatomical maneuver be the defining factor between your patient walking out of the hospital or never walking again?